Okay, so can somebody tell me the topic? What is the topic? I have stated that it's normal pregnancy, and can somebody tell me the topic? Slightly, the topic is a different topic, right? What is the topic?
Normal pregnancy, sir.
Normal pregnancy and anatomical and physiological changes, right?
Anatomy, clinical features, and diagnosis.
Okay, okay. So it's a I don't think I have anything new to tell, but this is only to recap what you know or what you have heard about pregnancy. Okay, so we will now. You all have studied, so you have gone through how the fertilization occurs in the fallopian tube and how it is being transported into the endometrium, and in the it changes throughout few days. In the next 4 5 days, the fertilized zygote will divide and it forms forms blastocyst, and the blastocyst on the day 7th or 8th of the following the conception, it implants in the endometrium and it grows as an embryo and it develops as a fetus. Okay, so this there are lots of things when you do obs and gynae, the terms that you should be familiar with. So this picture describes, okay, the ovulation. Soon after the ovulation, the ovum will be viable for 24 hours or 30 up to 36 hours, and the sperms will be viable for another few days, 20 48 up to 48 to 72 hours. And if they meet that successfully, that if it meets the ovum, uh, then the fertilization would occur. That becomes zygote in the that happens in the fallopian tube, and again through the tube it is being transported into the endometrium, and day 7 the blastocyst will implant and grow as an embryo. So when implantation occurs, the growing embryo will syncytiotropoblastic cells will produce beta HCG hormones and some other hormones as well. These will manifest as signs and symptoms of pregnancy. This will lead to the signs and symptoms of pregnancy. Okay, so normally you should know the fertilization occurs soon after the fertilization. You know, when the fertilization occurs, we conventionally calculate the expected date of delivery from the first day of last menstrual period. So that is very important. Okay, so we calculate. So we although the last menstrual period. So this day, this menstruation and ovulation you can't predict. But however, in a 21-day cycle, if the cycles are 28-day cycle, you assume that it would have taken 2 weeks. Okay, so if it is more than irregular cycles, you have to mention it in the history. She does not have regular cycles. However, the last menstrual period was this, and the day according to that, the expected date of delivery will be this, and she is at her gestational age of 28 or whatever the age. ඒ වගේ කියන්න ඕනේ. And if the cycles are irregular, you have to confirm the dates with an ultrasound date around 10 12 weeks. That we will discuss again and again, don't worry. Okay, so the duration of pregnancy, from the time of fertilization or from the last period to the expected date of delivery will be 280 days. But actual embryonic age will be 266, deducting the dates that are from that has been counted from the last menstrual period uh, to ovulation time. Okay, so that 14 days will be deducted to give an embryonic age. However, duration of pregnancy, conventionally we calculate from the last period to the expected date of delivery, that is 28 days. You should be familiar with calculation methods. Okay, so this is very important when you talk about pregnancy. if you don't know how to calculate the dates, if you don't know the principles of calculating the dates, and if you don't know how to tell certain things in a scientific form, these basics, then you sometimes, we have even failed, or we you can be penalized in the exams. Okay. And actually, if the dates are even, whether the dates are accurate, whether her last period is, whether she is certain about her period or not, okay, you should confirm the pregnancy by dating scan. That we do from 10 days to 13 weeks plus 6 days time. From the 10th week onwards to 13 plus 6 days. During that time that is the time where we can calculate the calculate the gestational age or expected date of delivery accurately, using a parameter of the fetus that is called crown rump length. Okay, we calculate based on the crown rump length, and if that date, expected date calculated by using the crown rump length, if there is a discrepancy, if the scan dates, if there is a discrepancy between the scan date and the her LMP date, if it is more than 4 days difference, you have to take the ultrasound scan date. That is the basic principle. Okay, so you have to always ask from the mother when you take a history. Okay, so if the crown rump length given expected date differs from her LMP given EDD by more than 4 days, so 4 days, then you take the crown rump length, because that is the most accurate date. Okay, after that, after 13 weeks, second trimester scans, we go by the HC, head circumference value. So this is the crown rump length we have taken, and this is the crown rump length. This is the head circumference. So in the second trimester, if there is a discrepancy of more than 7 days, we take the head circumference value. Okay, that you should know. Okay, so to tell, if you, when you present a history, you should take certain things, whether she is, to say that she has a regular period or her ovulation is correct, or to prove that, you should ask from her whether she is on any hormonal contraceptive pills, whether she was having regular periods, or whether she was on whether she was on any whether she was breastfeeding. Those 3 things you should know. Just, in the history, you should add these things in the history to say that her ovulation would be correct or might be correct. Okay, so you should know those things when you take a history. And when she conceives after, in the early pregnancy, so we divide the pregnancy period into 3 trimesters: first trimester, second trimester, third trimester. Okay, so up to 12 plus 6 days, we call it first trimester. 13 plus 26 plus 6 days, you call it second trimester. Beyond that, you call it third trimester. Okay, and there is a term called viability. Viability means, this is viability, is the potential of the fetus to survive outside the uterus following birth, like natural, or whether it is a natural or induced or cesarean section. When supported when given enough support, that baby, that fetus should be able to survive outside the world, so outside the uterus. So that is called viability. In Sri Lanka, we used to call it the viability. It's a kind of, there is a discrepancy or debate. Now in Sri Lanka, up to now, we call it 28 days. 28 weeks is the time of viability, but it has brought forward to 26 weeks. But our perinatologists, perinatal society, or the family health bureau is trying to bring it forward to 24 weeks. However, there is a discrepancy. So in Sri Lanka, it's still 28 weeks. WHO in other countries or developed countries, it is 24 weeks. So beyond that, the baby should be able to survive. So that is the time that is the period of, that is called viability. Okay, beyond 24 weeks, baby is viable. Less than 24 weeks, baby is not viable. Okay, so that is one thing. And give me a second. I have okay. So and also the term, the word called term. Term in the sense viability, and the other thing is term. Term is when the baby completes 36 plus 6 days or beyond 37, after 37 weeks, baby is called, it's a mature baby or term baby. So from that, the term means it's a range, not only 37 weeks, 37 weeks to 42 weeks time. That is the time in which we call it term. Less than that, preterm. After 42 weeks, you call it post-term baby. May terms you should know very, these viability, term, post-term, preterm, you should know. There is another, there are two things, terms you should know. One is gravida. Gravida kiyanne number of times that the woman has been pregnant. Gravida 7 kiyanne that woman has been pregnant 7 times. Parity kiyanne the baby, the pregnancy that has passed 24 weeks or more, regardless of outcome, whether it is a dead or alive. Number G7 P3 kiyanne, she has been pregnant 7 times, and she has had 3 pregnancies that has passed 24 weeks. You don't know the outcomes, whether it is a dead baby or a live baby, you don't know, but babies have grown beyond 24 weeks. That is called parity. Okay, so gravida, parity, you should know all these terms. Now I know it's these all the terms. No, I can't explain in detail. You have to read around the topic and understand further. Okay, so if you read 10 teachers, you will have a better idea. Okay, so diagnosis. In the pregnancy, usually we detect the pregnancy by doing a urine HCG test, urine beta HCG. That can be, that can be present, even soon after, around 3-4 weeks time, because the blastocyst or syncytiotrophoblasts will produce beta HCG on even 8th, 9th day itself. It will start to produce hormones that will appear in the urine also. Based on the urine strips you try, it can show pregnancy. So even soon after 1 or 2 days, even just before 1 or 2 days of her next period, the date, she can have a urine positive test. So when the urine is concentrated, especially in the morning hours without dilution, it can show positivity. And it is a qualitative test. Urine test, usually it's a qualitative test. And the blood serum values, there are serum tests in the serum beta HCG. Those can be quantitative and qualitative as well. So this shows 2 lines, and the pregnancy will be detected. And soon after, the first thing is they started to vomit, they feel tiredness, nausea, and GORD symptoms, gastroesophageal reflux. So all these symptoms will start to manifest because of the beta HCG hormones that act on various centers in the brain. So that triggers vomiting. So tiredness, fatigue, and missed period. So you have to, when you should know these things when you take a history in the soon after this. So patients will tell various stories. So you don't have to tell everything in her language, but you have to interpret, give a value to that, and tell, okay, when she missed a period and started to vomit, she suspected this could be a pregnancy, and her urine HCG showed a pregnancy test, positive test in the urine. So hence, since then, or after that, she registered herself in the field clinic. ඒ වගේ කතාවක් කියන්න පුරුදු වෙන්න ඕනේ. This is why you learn these things, okay? And also signs of pregnancy. These are very old and techniques, okay? So to show that she is pregnant, that time urine tests were not available, ultrasound facilities were not available. So they used various techniques. Basal body temperature that increases because of the increased progesterone hormones, and they feel warm, Okay, there are signs called Chadwick signs, Godel signs, Osiander sign, Haga. All these signs are there. So I'll show you the for signs just to know these things. And so there are few signs you should know. It's these are good to know stuff. In good old days, they used to do this test to diagnose. Chadwick sign. This is because blood flow increases in the vulva and cervical region. So this appears as a pinkish structure. Cervix and the vagina appears as a pinkish, bluish pink appearance. This is called Chadwick's sign. Godel's sign. When you do a vaginal examination, the cervical part appears as a soft tissue. It becomes very soft. So this is called Godel's sign. Osiander's sign is pulsatility. The blood vessels in the uterus will start to flow, have high blood flow. So when you put the finger in, when you will feel the pulsation, vaginal or blood vessels pulsating feeling. You will feel those, blood pulsating feeling. That is called Osiander's sign. Haga sign, it is the softness between, when you do a bimanual examination, you can feel the isthmus of the uterus very softly in between your fingers. That is called Haga sign, because this happens because that region becomes very soft and you can easily feel it. So this is called Hagas. So Osiander's, Hagas, Chadwick's, and Godel's sign. All these signs are there. You don't have to know that in detail, but you should. These are good to know stuff. Okay. So confirmation. When the urine HCG is positive, you don't go and do a scan straight away, because it can be 4 weeks or 5 weeks. Doing a scan will not reveal anything. Okay. But you can do a scan around 5 to 6 weeks onwards. A vaginal scan will show something in the uterus. If it is an intrauterine pregnancy, that is an endometrium in the small blackish hole-like thing in the endometrium, implanted in the endometrium. That is to show, that will help us to identify, okay, this is an intrauterine pregnancy. Sometimes this pregnancy can implant outside, so that forms an ectopic pregnancy. So if you have any doubt, around 5 to 6 weeks, if the patient comes with an abdominal pain, or if the patient has had previous ectopic pregnancy, then you may have to do a scan to locate the pregnancy. So in that case, 5 to 6 weeks, you can do a transvaginal scan, or we can do a transvaginal scan. The probe goes into the vagina and that will locate the endometrium, or the small blackish patch or intrauterine pregnancy inside the uterus. So can locate the intrauterine pregnancy. Sometimes if there is no intrauterine pregnancy, we move around the probe and see whether there is an ectopic pregnancy. Or that is, sometimes you don't see either in the uterus or outside also. That means pregnancy of unknown location, urine. All these things will be discussed in detail in different topics. Okay. So also after 6-7 weeks, you can do a scan to show the heartbeat of the fetus. So 6 weeks onwards, so 5 to 6 weeks, heartbeat will slowly appear. So that means the baby, that is to show the viability. That viability is different. Okay. May viability is completely different from that 24 weeks viability. This one just to see whether baby's heartbeat is there, baby is alive or not. So that is viability scan kila kiyanne. So more than that, in the early pregnancy, we use the dating scan around 10 weeks to 13 plus 6 days time to show, one thing is to correct the date, to confirm, to locate the pregnancy, and also sometimes early pregnancy complications. Sometimes molar pregnancy, sometimes early pregnancy loss, so miscarriage, all this can be diagnosed around this time. Okay, so symptom wise, patients, according to the POA, this list of this chart shows lots of, there are breast changes, tingling sensation, pain, painful and tender breasts. So they become amenorrheic, nausea, vomiting. Sometimes urinary frequency will increase, and body tiredness. Some people even don't realize until they feel the quickening. Quickening यानी first baby movement in the uterus around that can be felt around 16 to 20 weeks time, and all these signs. So these are symptoms of pregnancy. Okay, so those days, the patients, since there is no scan, no health, urine pregnancy test available, so these people sometimes straight away went into labor without knowing what did they have. Even this can happen to young girls, no, without any unmarried girls, when they conceive without knowing these symptoms, they continue the pregnancy, and only in labor it has been recognized. So these symptoms are important for you to symptoms and signs and symptoms, breast changes, all these things are, you should know these things. Okay. So most importantly, those are some physiological changes I described, and this body undergoes or adaptation or body changes when there is a growing fetus to facilitate the blood flow to the baby, and to uh, facilitate the accommodate the growing baby or fetus inside the uterus, and to facilitate or help her to deliver without any, deliver vaginally. Oh, these are the main objectives. So the whole system, it can be a cardiovascular system, it can be the renal system, skin, musculoskeletal system, and respiratory system, central nervous system. All these body systems will make sure that they undergo various changes, physiological changes, anatomical changes, and all these changes will finally, ultimately help the growing baby to grow without any problem and to deliver uh, uh, without any issues. These are the aims of this, and to these changes will facilitate. That is the main aim. So to help the growing baby is the main aim. However, these changes, while helping the baby to get nutrition and support, they also give rise to symptoms in pregnancy. So patients will invariably will undergo certain physiological changes and discomforts, or they will face various discomforts. These changes will manifest as various discomforts, and you or we as medical practitioners should be able to understand, okay, this is the physiological changes, and sometimes this can mimic, or sometimes this even a major health problem, heart failure also can present like this. So you should be able to differentiate. So for example, heart, when the heart is an organ that helps to pump the blood, no, so when the baby fetus is growing inside, baby needs lots of blood, growing uterus needs more blood, so the heart has to work. So heart pumps a lot, heart rate increases by 10 beats per minute, so she will be having a tachycardia. Okay. And total peripheral resistance in the blood vasculature or venous system will reduce, and so that she will have a blood pressure will drop slowly, blood pressure, total peripheral resistance, and venous return will reduce. However, heart has to pump a lot of blood, cardiac volume, so end diastolic volume will increase, and cardiac output will increase by more than 40% or 50%. So in that case, cardiac output as well as stroke volume will increase. Cardiac output plus, when the stroke volume increases, that will help the baby to get more blood. So uterine blood supply will increase. Okay. So resting heart rate will be increased by 17%. Okay. And blood pressure will drop. So all these changes will happen slowly from the time of conception to towards the, now cardiac output will peak around around 28 to 32 weeks. That is the time where she feel mostly little dyspneic, she will feel discomforts, and when she is lying down feeling difficulty in breathing. In the meantime, if she has a heart disease, she will feel it more often, and it will worsen the situation. When she can't walk about at least few feet, she can't even walk a little bit, she can't even climb a staircase, that can be something different and you may need to investigate further. If there is a heart lesion, this will manifest even seriously. Okay, you should know these are the cardiological changes, cardiovascular changes. This is a small summary only. It's a large area. You should read and understand what cardiac changes occur anatomically, physiologically in a pregnant woman. Okay, so there are anatomical physiological changes, as well as this will be manifested in the chest X-ray as well as ECGs also. You have to list down and understand. Okay, so cardiovascular changes, cardiac output will increase, blood volume will increase, the total peripheral resistance will reduce, blood pressure blood will reduce, cardiac output, stroke volume will increase. Okay, cardiac, these things you should know. In the meantime, parallelly, respiratory system will also undergo various changes. So patients will start to have increased breathing rate. They will have a they will have a kind of rapid breathing. So that is normal. So this is hormone induced, and the tidal volume will also be increase because of the increased rate. Okay, so carbon dioxide will be washed out very frequently. Also, there will be an alkaline environment. Okay, so these things you should know. These there are lots of other changes also. So vital capacity will not change, and tidal volume will increase. So there is a graph. Unfortunately this graph I updated. I don't know whether it was, yeah, I will show it. So it is there, it must be there. So there is a graph that for respiratory changes in a non-pregnant woman and respiratory changes in a pregnant woman. All these things are described in that, when you browse online, you will get that. Please go through that. There are lots of MCQs. This is a very important concept to know the pregnancy. So many MCQs are there. Respiratory changes in a pregnant woman. What will happen? Diaphragm will push the lungs up, and vital capacity. What is going to the vital capacity? What will happen to the tidal volume? What will happen to the respiratory rate? All these things are there. You should read and understand. Gastric reflux, because of the progesterone hormone, lower esophageal sphincter tone will reduce. So whatever, and also gastric emptying will reduce. So a lot of stuff that you ate, that a pregnant woman has eaten, will stay. So reduce the emptying. So whatever is inside in the stomach will be thrown up, and she will be prone to get gastric esophageal reflux disease. Okay, so increased risk of cholesterol stone formation also, because gallbladder emptying is also delayed. This is the graph I wanted to show you. So just Google it and find out, or I will share the presentation, or you may have the presentation. This is very important. So this is, again, you should know, when the patient comes with breathlessness, it is not always due to pathology. This is a pregnancy induced, hormone induced. So mostly they complain, I have a little breathlessness at night, doctor, but I am okay with my work. That means, this is physiological. So if the patient is panting all the time, she can't even walk. She just walks into the bedroom, she gets the panting, or she gets dyspneic. In that case, we may have to look for a cause in the respiratory system or in the cardiovascular system, or maybe can be anemic also. So you may have to, you need these principles to evaluate a patient. Genitourinary system, as I said, cardiac output will increase. Lots of blood will be pumped to the kidney system or renal system as well. Kidneys will enlarge a little bit, and GFR will increase, and lots of urine output. However, because of this dilation, and results in reduced creatinine value in the serum level. So these changes will reduce the. So when you do an analysis or the urine test or blood test to assess the serum creatinine level or serum creatinine level, it will show a little less value than the non-pregnant woman. Okay, so increase renal flow, increase kidney size, GFR will increase. These things will, this can be asked in MCQs. Okay, there are lots of MCQs coming in this area. So don't stick to these functions only. Just a little more reading is will be helpful. Genitourinary system. What are the changes in the pregnancy? Okay, what parameter, what functions in the kidneys, what anatomical changes would occur? So, for example, hydronephrosis, ureteric dilatation, that is physiological. So, okay, so that is normal. If you see a little bit of hydronephrosis in pregnancy and enlarged kidneys, that finding is a normal thing. Okay, so these things you should read and know, understand. Okay, kidneys, the red cell indices, so hemopoietic. Wait, give me a second. These changes also. One is red cell volume will increase, or hemoglobin concentration will reduce, because proportionate to the red cell volume, more than that, there will be a fluid accumulation also. Body fluid volume will increase. Red cell mass also will increase. However, there will be a dilution because volume expansion is more than the red cell mass. So when it exceeds, hemoglobin concentration will show a diluted level. Okay, so this is, you should know. Reticulocyte maker, I can't explain. You should read and understand the pathophysiology. Okay, these are the changes. That is it. ESR will increase. Coagulation factors will increase. Platelet count slightly will reduce. All these things actually systematically occur in order to help the woman. Because if you see, for example, now hemodilution occurs. So when she delivers and bleeds, she won't lose much of the hemoglobin. Okay, so it is a diluted blood, diluted volume only, and coagulation factors will increase. That will make sure clotting functions occur, and the bleeding will settle soon after the delivery of the baby. Okay, all these functions, actually clotting parameters will increase. However, this will lead to increase or predisposity towards deep vein thrombosis. So that is also one disadvantage. However, coagulation factors will increase, but however, there is a balance. So procoagulants will increase. So you should know what kind of procoagulants will increase. All these things, read and understand. I can't, this is again a major area. So hemopoietically, hematological system, if you know this much, that is more than enough. But to score more, to understand more, you should read around the changes that occur in the hemopoietic system. Endocrine, insulin level will increase, and that is one of the key things that occurs in pregnancy. And this manifests in the fasting hypoglycemia, because when you do a blood sugar level, so most of the women will come, doctor, mage fasting aduine. So when you check it, you have to explain it is because of the hyperinsulinemia, and you have increases the metabolism. Okay, and thyroid will enlarge, vascularity will enlarge, and more they will come up with a slightly detectable goiter. These are physiological and it is normal. And very common thing is musculoskeletal system, because of the hormones that produced in the body, relaxin killer hormone and progestogens. All these hormones will relax the body joints, ligaments and all. So because of that, they get various back pains and aches, suprapubic pain, pelvic pain, back pain. So these are very common. Okay, so effect of relaxin hormone, so increase mobility of the joints, especially that will start from the beginning of the pregnancy. And these complaints, commonly they come up with suprapubic pain, that is the little bit of subluxation or little inflammatory changes occur in the pubis symphysis joint, that is called SPD kila. SPD, that separation causes a significant pain. Symphysis pubis dysfunction kila kiyana. So you should know that All these are due to the relaxin hormone. And when the baby is growing, because of the body changes its position, gravity uterus එක ලොකු වෙනකොට body anatomical changes, so it affects the on the back pain and spines, and the gravity changes, and it also increases the weight bearing effect on the knees and the heel. All this causes aches and pains. Okay, so see, abdominal muscles will stretch and increase mobility of the symphysis, pubis, and sacroiliac joints. All these effects occur, and they finally come to us with all these pains, and we can't treat. We have only some helpful measures, home remedies, and also tender loving care. You have to understand that, and whenever they come to you, you have to listen to her. You have to offer some remedies, some pain reliefs, and maybe a physiotherapy will help you. However, this pain, for example, if they come with back pain, you can't always ignore saying it is normal back pain. It can be hydronephrosis, and it can be a acute pyelonephritis. It can be a sacroiliac. We have had patients with abscess in the sacroiliac joint, abscess in the pelvis. All these people are also present with same pain, and different type of, sometimes flare up in the SLE, or sometimes flare up of rheumatoid arthritis. So you have to listen you investigate further, and only you can investigate and identify. So all these symptoms may mimic different serious problems also. Having a good knowledge in the anatomical and physiological changes and the consequence in pregnancy will help you to differentiate from a real pathology. Sometimes you should always have a suspicious mind in order to exclude serious problems. Recently, I had a patient she had a subluxation or sacroiliac joint had an inflammation, and actually that separated, and she could not walk in pregnancy. Okay, so that was a serious issue. It's like an orthopedic emergency. However, we thought it could be a neurological problem. It thought initially it could be some functional issues. We thought it could be something related to kind of muscles alone. However, an MRI was used to find out that there was a subluxation in the sacroiliac joint, and piriformis muscle was torn in that woman because of the severe infection, and that was due to some hematogenic infection. So the knowledge that you gather, or maybe in pregnancy, physiological changes, anatomical changes are very important to identify or to differentiate from the pathological conditions in pregnancy. So this hip joints, and there is a condition called pubic symphysis dysfunction, or SPD, very important. A lot of women come with that symptoms. Sometimes you should be able to differentiate. It can be due to abruption. When they point out that area and say, I have a severe pain, you should be able to take a history. Could it be an SPD? Could it be an abruption? Could it be a maybe scar? Sometimes it could be a urine infection or some ovarian cyst accident. All these things should be kept in your mind to differentiate. Uterus, what will happen to the uterus? Uterine vessel size will increase, volume will increase, and it will expand. From 12 weeks, it is at the suprapubic level, and slowly it will expand, and around 20 weeks, it will be at the size of an umbilical level. Okay. Breast tenderness, tingling sensation start from first trimester. Breasts will enlarge, nipples will enlarge in size, and also become hyperpigmented. So all these are normal, and this hyperpigmentation is an irreversible condition. Okay. So all these changes, today you read and make a note. What are the pregnancy changes in the pregnancy changes, physiological and anatomical changes, and make a list. And I will send you an article also. Just go through and identify, do a lot of questions, and this will be definitely you will be having a having few MCQs. Okay, we are given when we set questions, they will send this topic as an important topic to gather or set questions. Okay, so please please go through that. I will share share some presentations or this presentation as well as an article with you. Okay, any questions? Okay, in the absence of questions, I'm going to wind up now. Okay, guys.
Thank you, sir.
Okay.